Welcome to the CNS 100 series. I am Dr. Sohail Syed, one of the Complex Spine Fellows at Brown University, and today we'll be covering Sub-Axial Cervical Spinal Anatomy and its clinical considerations. The subaxial spine versus the CVJ, craniocervical junction. The subaxial cervical spine refers to the cervical vertebrae below C2. This division of the cervical spine into O, C1, C2, and the subaxial cervical spine is done for both anatomical and functional reasons. The subaxial cervical vertebral bodies have roughly the same structure and shape, whereas C1 and C2 have very distinct morphologies. As a result of this, the pathology, especially trauma and fracture patterns of these two regions, are distinct and raise unique issues and concerns. Furthermore, surgical management and techniques in these regions are different. Basic subaxial osseous anatomy, the anterior elements. The subaxial spine consists of a similar structural motif that is carried through each level. Anteriorly, there is a vertebral body, which ranges from 15 millimeters to 25 millimeters in width, 10 millimeters to 15 millimeters in depth, and 10 to 15 millimeters in height. This is flanked bilaterally at the posterior aspect of the vertebra by diminutive bridges of bone referred to as the cervical pedicles, which connect the vertebral body to the lateral masses and the posterior elements. The cervical pedicles typically range from 1 to 1.5 millimeters in length and 5 to 10 millimeters in width. Immediately lateral and anterior to the pedicle is a transverse foramen which accommodates the vertebral artery. This foramen is bounded anteriorly and laterally by the transverse process itself. Subaxial osseous anatomy part 2, the posterior elements. From the lateral masses onwards, the remaining bony structures constitute the posterior elements. Much like the other regions of the spine, the posterior elements of the cervical spine form a bridge around the dorsal aspect of the spinal canal and spinal cord. The paired lateral masses form the base of the bridge and have a shape resembling a parallelogram. They typically have an average depth of 13 millimeters, an average width of 12 millimeters, and an average height of 14 millimeters. The lateral masses have a superior and inferior process referred to as the articular processes. These join with the processes from the level above and below to form the facet joint. The lateral masses are immediately attached to the cervical lamina, which have an average laminar height of 11 millimeters, width of 15 millimeters, and thickness ranging from 2 to 5 millimeters depending on the location along the lamina, typically widest at the center. Finally, a single spinous process is found at the meeting point of the two lamina. The spinous process is an approximate length of 15 millimeters. Of note, the C7 vertebrae tends to have a taller and narrower lamina along with a longer spinous process compared to the rest of the cervical vertebral levels and is typically easily palpable. Subaxial soft tissue, the discs, joints, and ligaments. Compared to the rest of the spinal regions, the intervertebral discs at the cervical spine have a unique articulation with the vertebral bodies. The uncovertebral joints of the cervical spine constitute a smile-like shape which consists of the uncinate process of the vertebral body below and the corresponding recess within the vertebral body above and the disc between these two structures. These joints serve to stabilize the cervical spine through its wide range of motion, especially lateral bending. The cervical discs, like the bodies, are much smaller than their lumbar counterparts with an average height of 5 millimeters and similar width and depth as the vertebral bodies they cushion. The vertebral body and disc are reinforced anteriorly and posteriorly along their surfaces by the anterior and posterior longitudinal ligaments. Dorsal to the spinal canal and thecal sac runs the ligamentum flavum. It is important to note that the ligamentum flavum is not continuous, but rather spans from the bottom half of the rostral lamina to the rostral edge of the inferior lamina in a discontinuous fashion. This has surgical relevance for decompressive surgeries as there is no protective ligament at the rostral half of each lamina. The lateral masses of the adjacent levels articulate to form the facet joint as mentioned before. Each joint has two articular surfaces, the superior articular process, which is given from the lower cervical vertebrae, as well as a inferior articular process contributed by the upper cervical vertebrae. This joint has a cartilaginous capsule to which the overlying paraspinal musculature attaches. Subaxial nervous structures. The cervical spine contains 8 pairs of cervical nerves which supply sensory motor function to the neck, arms, and diaphragm. The nerves C1 through 4 primarily supply various muscles and dermatomes of the neck, while C4 through 8 supply various muscles and dermatomes of the upper extremity and upper chest. Unlike the thoracic and lumbar nerves, which are named in relation to the pedicle under which they pass, the cervical nerve roots are named in relation to the cervical pedicle that they travel above within a structure called the neurosulcus, a groove that extends from the medial border of the cervical pedicle to the lateral edge of the transverse process. The overall length of this groove ranges from 15 to 20 millimeters. From here, the nerve roots continue anteriorly to give rise to the ansa cervicalis for the upper cervical roots and the brachial plexus from the lower cervical roots. Subaxial vascular structures. The vertebral arteries are the major vascular structure of the cervical spine. After arising from the subclavian artery, the vertebral arteries will typically enter the C6 transverse foramen and continue their superior ascent sequentially through each transverse foramen. However, there is variability to this course. The vertebral arteries may enter earlier at the C7 transverse foramen or delay their entry till the C5 transverse foramen or beyond. In between the transverse foramina, the vertebral artery may swing medial and impress into the vertebral body, or swing anteriorly and run along the anterolateral surface of the vertebral body. Recognizing the position of the vertebral arteries and its variations is essential to performing safe cervical surgery, especially in anterior cervical approaches. Subaxial spine biomechanics. The subaxial cervical spine predominantly performs the functions of flexion and extension, with some degree of lateral bending and rotation as well. The anatomy of the facet joints and the uncovertebral joints link these three movements together so that lateral bending also requires the ipsilateral facet to posteriorly rotate and the contralateral facet to anteriorly rotate. Each motion segment or disc level provides 10 to 20 degrees of flexion and 2 to 7 degrees of rotation, with the highest range of motion provided by the mid-cervical spine, especially C4 through 6, which explains in part earlier degenerative changes noted at these levels. Subaxial spine trauma. Cervical spine injuries are seen in approximately 1 out of every 30 trauma patients. These can be seen in both high-velocity traumas such as MVCs, as well as low-velocity traumas like ground-level falls. Proper identification and management of these injuries is necessary for ensuring best patient outcomes. Several classification systems exist in order to create a standardized language to convey the type of injury and its relevant anatomical parameters, and to use that information to determine appropriate management strategy. The overarching goal of these classification systems is to determine whether an injury is unstable or stable, and to hint at what sort of surgery might best treat the instability. Two of the most commonly used classifications are the Subaxial Cervical Spine Injury Classification System, SLIC, and the AO Spine Classification System. Essential to both systems is defining the integrity of key stability providing structures, such as the disc and vertebral body anteriorly and the posterior ligamentous complex and facets posteriorly. The AO Spine Fracture Classification. The AO Spine Association has a standardized classification system to allow for consistent reporting of fracture types. A standardized system aids clinicians in conveying information and in research endeavors by creating a common, shared, easy-to-use nomenclature. There are 3 major categories of injury patterns: A-type compression injuries that crush the vertebral body, B-type tension band injuries that either tear through the anterior or posterior half of the spinal column, and finally C-type injuries, which are complete disruptions of both the anterior and posterior spinal columns. Finally, an F-type injury, which is unique to the cervical spine, may simultaneously occur with any of the above types of injury, and specifically describes injuries to the cervical facet joints, with injuries F2, F3, and F4 being relative degrees of unstable. The SLIC scoring system. The SLIC scoring system provides a simple clinical decision-making tool for deciding between surgical versus non-surgical treatment for cervical spine fractures. It consists of 3 major components: fracture morphology, integrity of the disc and ligamentous structures, and finally the neurological status of the patient. Surgical patients are those with a total score of 5 or greater, while non-operative patients are those patients with a score of 3 or less. A score of 4 is indeterminate, and either strategy may be appropriate with the patient factors taken into account. That ends our slides discussing cervical anatomy. We hope that this has been educational for the listener and adds to your greater understanding of neurosurgery. Thank you.